Hi, my name is Dr. Cheryl Chrisman, and I'm a small animal neurologist at the University Veterinary Teaching Hospital at University of Florida. I've been here for about 25 years, and I teach the first and second clinics for juniors and seniors. And so I'm very happy to be here with you today to give you this review, and we are going to talk about small animal neurology and review some topics that should be of interest to you, and also some help in passing the national board. So these are the problems that we are going to review and go through evaluation of cases, neurology cases that have seizures, neck or back pain, quadriplegia, paralysis of all four limbs, and paraplegia, paralysis of just the hind limbs, head tilt, nystagmus, and disequilibrium, which is balance disorders. These are the four most common complaints that dogs and cats bring to a small animal hospital. These also are questions out of this material. Is on the board exam. I reviewed the seniors, and they said this kind of material would be very helpful for you. So I wish you good luck. So let's get started. The first thing that we're going to talk about is seizures. And I know that all of you that have been in the small animal practice know that a lot of animals are presented with seizures. And so let's start first with a definition of what seizures are. Seizures are an electrical disturbance of the brain which produces clinical symptoms, some kind of sign that we can see that the animal manifests as a result of this abnormal electrical activity. So it's almost like a brain storm. That's the little picture there. There are definitely several different causes of epilepsy, seizures. There's primary epilepsy, which is a type of inherited seizures, and there is secondary epilepsy, which is due to some type of intracranial disorder going on, like a tumor or like an encephalitis or something like this. And then there are extracranial disorders that cause seizures. And examples of that are hypoglycemia or liver problems. So, and certainly toxicities, intoxications. These are some of the extracranial causes. So we have intracranial causes and we have extracranial causes. Some of the intracranial causes are going to be active disease processes like encephalitis or tumor, and others are going to be just a little focus of damage or some kind of inherited problem in their neurons that this electrical brainstorm occurs periodically and produces a clinical seizure. So let's first talk about extracranial causes, kind of a reaction of the brain to these seizures. Now, extracranial causes are things like hypoglycemia, low blood glucose, hypocalcemia, low calcium, some kind of liver problem, and the most common that we see, of course, is the portosystemic shunts. And this is the extrahepatic shunt that the blood doesn't go through the liver, and all the toxic byproducts from metabolism collect in the brain. And certainly intoxications. We have a lot of problems with organophosphates here in the state of Florida, and people overdosing their animals on ivermectin, and so these can all cause seizures. Thiamine deficiency can cause seizures. However, if they're fed the good brand dog foods, most of them have plenty of thiamine in them, or cat foods. And the diagnosis is really based on the history, and if the seizures are symmetrical, like both sides of the body are doing the same thing, that's a real important aspect in history to ask the clients. And lots of times we have them send us a video so we can actually look, because sometimes they're real upset while the seizure's going on, and they might not really notice if it's symmetrical or asymmetrical. So, but if it's symmetrical, or we witness the seizures and they're symmetrical, then certainly we can think of these extracranial causes of seizures. And then, of course, we're going to do some blood tests, because much of, like, hypoglycemia and hypocalcemia and liver problems, we can diagnose from a routine complete blood count, a chemistry profile, a urinalysis, and serum bile acids to test liver function. So this is how we diagnose this reactive type of seizures. So if the serum glucose is low, that tells us we're dealing with hypoglycemia. Then we have to figure out what's going on to cause the hypoglycemia, but at least we know the cause of the seizures at that point. The second one is serum calcium, and if they again have hypocalcemia, low calcium, then we know that the seizures are caused from that, and then we have to just figure out what's causing these seizures. And then the bile acids, that's what we do to check for liver problems. And usually we do a fasting bile acids, and then we feed them a little bit, and do a 2-hour after feeding, the postprandial bile acids. And the elevations of that indicate that the liver is not functioning properly. We will do a serum cholinesterase if we suspect organophosphate toxicity. And most of the time, if the animal has seizures from organophosphate toxicity, the level is below 500 international units, where the normal would be 1,000 to 1,200 international units. Once they get below 500 international units, they're going to seizure. And then if lead exposure is a possibility, if they have a history of fishing and eating lead sinkers, or if they have ceramic dog dishes, or if there's peeling paint or caulking compounds or golf balls, these are all sources of lead. And if we do a blood lead, we can see if they're in the toxic range, that that's probably why they're having seizures. So these blood tests can be a great deal of help to help us realize that there is something going on outside of the brain that's only secondarily affecting the brain. Then we can have epilepsy, seizures that are due to something going on inside the brain. Some people call this symptomatic epilepsy. The classifications are kind of goofy right now in the veterinary field and in the human field. They're undergoing some transitions, so you might see some new classifications down the line, but this will get you through for now. The secondary or symptomatic epilepsy is associated with either residual damage in the brain from some previous process. So there's no like active process like an encephalitis or anything going on, but there is a little focus of brain damage that acts as a site for these seizures to take off from. Or you can have an encephalitis, an infection of the brain. Another name, meningoencephalitis, is infection of the brain and the coverings of the brain. You can have a brain tumor that's causing seizures, hydrocephalus, which is water on the brain. And the diagnosis for these type of disorders now are some kind of special tests that we have to do usually in a specialty hospital, and that's the EEG, the brain waves, CSF analysis to see if there is some kind of infection going on, and a CT or MRI scan. Now, these tests are not done in a routine small animal practice, but they are tests that you need to know about so that you can offer your clients this type of assistance from a specialist. And also, just knowing what's out there in veterinary medicine and what people are doing is very important, and will also probably be on the board somewhere. So this is how we evaluate intracranial disease. It gets a little bit trickier once you move into the brain. So treatment of seizures is one of the biggest challenges that we can have. And so first off, we have to treat any underlying disease. If it's something going on outside the body, like low blood glucose or like hypocalcemia or liver disease, if we treat the underlying disease process outside of the brain, then we may not even have to give the dog any kind of anticonvulsants. Case in point, think of the little toy poodle that goes off food for a few days, maybe has vomiting, anorexia, and boom, starts having seizures. Well, we should think right away that a good possibility is that this dog is hypoglycemic, and just giving him glucose will stop the seizure disorder. And from then on, we can tell the client, now make sure if he goes off food that you at least give him a little Karo syrup multiple times a day and keep that blood sugar up, because he's a dog that's prone to having seizures when his blood sugar gets low. Most of the time, we have to go to treat seizures that are going to be ongoing, like in a case of epilepsy. Epilepsy is ongoing seizures, and the seizures are kind of the symptom of the epilepsy. We need to usually go on some type of oral anticonvulsant therapy. Now, seizures that are not very frequent, we might be able to go use some alternative medications and alternative therapies like herbal therapy and acupuncture. But once the seizures get real frequent and violent, we might not be able to control it with just those modalities alone. And we probably should at least try some oral anticonvulsants to get them started. So long-term oral anticonvulsants are usually needed in the primary epilepsy, or the inherited epilepsy, it's called, or idiopathic epilepsy is another name for it, all these names. And for the secondary or symptomatic epilepsy that is associated with some kind of residual focus. So this is kind of like the epilepsy. Lots of times we call it idiopathic epilepsy because we don't know why they're having seizures. Everything else is completely normal. The dog is so totally normal in between the seizures, but just periodically has these seizures. And we have to treat these and figure out what's going on, how we can control them. So that's what this part's going to be on. The anticonvulsant therapy, for the most part, is an oral administration. And so this is for something that's going to maintain the seizures over the long haul. And we usually, people always ask, well, when do you start anticonvulsant therapy? We usually start anticonvulsant therapy when they're having multiple seizures, like more frequent than once a month, or if the seizures are occurring in clusters. And so this is when we start. And the drugs that we use are phenobarbital and potassium bromide. These two drugs that are listed up here, phenobarbital and potassium bromide, are two drugs of choice. Now you may say, if you're an older practitioner, gee, what happened to the primidone and the dilantin? Well, we don't use those much anymore because we've had some problems with it. Primidone causes liver problems, and dilantin doesn't work very well. And so we have found that with these two drugs, phenobarbital and or potassium bromide, we are able to control about 90% of the seizures associated with routine epilepsy. So that's kind of important information to know in a small animal practice. So let's talk about phenobarbital first. Phenobarbital is a really good drug to begin with if the animal is having frequent seizures multiple times a month. If they're infrequent, then we might not have to start with phenobarbital, but if they're frequent, we need to get that control right away. The dose varies with the animal. You can start out low and work up, 2 to 4 milligrams per kilogram. So what we're trying to do is to find some dose in that range that controls the seizures but has minimal side effects. And one of the biggest side effects that we have is sedation. So we need to adjust the dose to find what's going to work. Now, some dogs are sedated for about 2 or 3 days when you first begin the phenobarbital. And so we might want to wait a few days and see if they adjust, because this sedation can sometimes pass. Now, other side effects that can be troublesome are increased thirst, increased urinations, and if it's a dog that's already prone to having problems with drinking a lot or urinating a lot, that can be an issue. And polyphagia. Excuse me. Polyphagia. And the important thing is not to let these people feed the animal more than he needs. So I always say keep him on the regular diet, but he's going to beg you because he's going to have the munchies and he's going to feel like he's starving, but he's not starving. Phenobarbital is an appetite stimulant in some dogs. And if they are allowed to eat all they want, they're going to get very obese, and then that will lead to other problems besides the seizures. So phenobarbital is a great drug of choice. If we can go back to the slides just 2 minutes, I'd like you to focus on the last point, and that is serum levels. After they've been on a consistent dose for 2 weeks, we need to measure the serum phenobarbital level to see where we're at, because you cannot go by just a dosage to figure out if the seizures are going to be under control or not. You need to see what's going on in the serum, because we want to keep the seizures somewhere between 15 and 30 micrograms per milliliter. If a dog is difficult to control, it might have to be up towards the 30 end of it. And if they're easy to control, they might control at 15. But we need to find the range in which the seizures are controlled for this animal, and you need to do the serum levels to do that. Now, it doesn't matter when you draw the serum in relationship to when they get the pill, because once they've been on it for 2 weeks, then it reaches a steady state, and it's pretty much the same for the 12 hours. You give it every 12 hours, and so it's pretty much the same for that 12-hour period. So this is 2 to 4 milligrams per kilogram every 12 hours for the dose. Phenobarbital is a very effective drug for single seizures. It is not a very effective drug for animals that have cluster seizures. And that means more than one seizure at a time. Like they'll have a seizure, they'll kind of wake up a little bit, go in and have another seizure. There's some dogs, some routine epileptic dogs, that when they have one seizure, they will have 5 or 6 following that over the next 24, 48-hour periods. And in those dogs, the phenobarbital is not very effective. The phenobarbital can cause liver damage, so it is important that you check the serum bile acids on these dogs to make sure that the liver function is not being adversely affected by the phenobarbital therapy. Potassium bromide. Potassium bromide is the second drug that we use, and you can combine it with the phenobarbital, especially in dogs that are having cluster seizures that are greater than once a month. We want to get that phenobarbital on board so that the seizures will have some kind of control, because the phenobarbital will slow them down for sure. It might not totally control them, but it'll slow them down for sure. And so we need to get some phenobarbital on board. The potassium bromide takes a while, takes about a month to take a real good effect. Sometimes we'll see something in a couple of weeks, but you just can't count on it for a month. So you need the phenobarbital in the meantime till the bromide kicks in. Now, if they are having cluster seizures only once a month, then you can go right, or less, you can go right to the potassium bromide as your first drug of choice. Now, the reason that we like potassium bromide is it is very liver friendly. It is good in dogs that have liver problems. It totally bypasses the liver. It is excreted in the urine, and so you have to be careful. If a dog has renal disease, you do not want to give it because they can get very toxic from it. The disadvantage of potassium bromide is that it must be compounded by a pharmacist. It is not commercially available, and so, but any compounding pharmacist can make it up. It's just crystals, and you put it in water, and we usually make a liquid out of it, just water and the crystals, and sometimes the dogs don't like the taste, so the pharmacist will put chicken broth or some kind of tasty something in there to make it taste good. And but the liquid is best because we're going to go through a dosage adjustment period. And while the dosage is being adjusted, we want to make sure that we are allowing for some flexibility here. And if they are on capsules, if we pack the crystals into capsules, it's really hard to make fine adjustments in the dose. So go with a liquid. It's real important that the client wear gloves while they're handling it, and that we make sure the dog gets all of it. So I don't have them squirt it in his mouth. What I have them do is put it on a little piece of bread, put the bread in the dog dish, and then let the dog gobble up the bread. And that way, you know they got their total dose. If you try to just give it in a syringe in the mouth, half of the time it goes on the walls, on the client, and it's a real mess. So, it is important that you give it that way. Next slide. The dose is 22 milligrams per kilogram every 12 hours with food. And it takes a long time, as I said, to take an effect, about several weeks. But you have to wait 3 to 4 months before it reaches a steady state and you can measure the serum level. But once you're there, you need to measure the serum level. Even if the dog is completely controlled, it's best to measure the serum level because then you'll know what this dog's normal is. That way, if there's any other medications added or if things happen, you can always check that serum level and see if it's being maintained or if something is getting it out of whack, and that's why the dog is having more seizures. The overall look at seizures is that the prognosis is very good if the underlying disease can be treated. And if there's no active disease process, then really most seizures can be controlled by phenobarbital and potassium bromide in combination. And it's just those very few dogs that have a problem and are unable to have control with these drugs. It really takes adjusting the dose for each individual animal and monitoring those serum levels and just logically approaching this. You can control the seizures in most dogs that are epileptic. Okay, our next topic that we're going to review is the animal that comes in for neck or back pain. Now, the signs, this is so common. The signs that we're going to see is the animal will cry or yelp out for no apparent reason, or when the owner tries to pick him up, they'll cry out. And they'll bring in, he hurts somewhere. Well, most of the time it's his neck or his back. They may be reluctant to move their neck, like they won't lift their head up and look at the client, or they don't want to bend down their neck to eat. They might not want to jump on and off the furniture if they were allowed to do that. Oh, my dogs are. And they might not go up or down stairs, and they may stand at the bottom of the stairs and cry for the owner to pick them up and carry them. And sometimes when their back hurts, they'll arch their back up and they'll have their abdomen tucked up, and they really look like they're hurting. So this is the animal that I want you to get in your mind, because this is the approach that we're going to do on that. What kinds of things can be doing that? Next slide. So these are the causes of neck pain. Certainly one of the first things that you want to ask the people are, is there a possibility of trauma? Because if the animal just has neck or back pain from trauma, it's really important that we get some radiographs right away to see if there's a fracture. Because if there is, then this vertebrae can collapse and paralysis can occur. And so it's at that stage where they just have the pain that we'd like to get them and get something done. So if they have a fracture, try to get some radiographs right away, but boy, if you're going to give them any kind of sedation to get the radiographs, if they're in that much pain, you got to sedate them. Be incredibly careful about moving anything. Now, a lot of people say you should strap them to a radiolucent board and take the x-rays that way so that you don't move anything, because you could collapse the vertebrae and cause the animal to be paralyzed. And obviously we're here to help animals, and we certainly don't want to make any situation worse. The second most common disease that we deal with, especially in the sweet little dachshund that is on our screen here, is intervertebral disc disease. Dachshunds, beagles, bassets, Pekingese, Shih Tzus, Lhasa Apsos, poodles. Oh, this is just a common problem in small animal medicine and in practice. And so a degenerated intervertebral disc in the neck or the back can cause excruciating pain. So that's going to be right at the top of our list, especially in small chondrodystrophic breeds of dogs like the dachshund. A third possibility is an infection of the vertebrae called discospondylitis. Discospondylitis is usually a bacterial infection of the vertebrae, and boy, it is very, very painful. Meningitis can be caused from a variety of organisms, but quite honestly, most of the time, it is associated with an autoimmune process, or at least a suspected autoimmune process. And so there are no organisms present at all, and it responds wonderfully to oral prednisone therapy. And then, of course, the last on our list is some type of neoplastic process, either in the vertebrae or in the nerve roots or meninges, which are the coverings to the spinal cord. And so these are our 5 causes of neck or back pain that we're going to see in a small animal practice. Certainly one of the first things that we're going to want to do is take some radiographs of the spine, and these are the things that we can detect from just plain routine radiographs, good quality radiographs. And not the whole dog radiographs where you just put them on the plate and shoot the whole thing, but actually localizing the radiographic beam right on the site where they hurt. Because where they hurt is usually where the lesion is about 99% of the time. So what we can see on plain radiographs are fractures, calcified discs, infection of the disc in the end plates, the discospondylitis, that is, and some type of vertebral neoplasia, something that's eating away the bone or is causing proliferation of the bone. Now, meningitis can be difficult to diagnose without looking at the spinal fluid. So how we have to diagnose it is to collect a sample of cerebrospinal fluid. Now, the plain x-rays are going to be completely normal on that dog. So we have to collect a sample of the fluid that bathes the brain and spinal cord and look at the number of white blood cells in there. Now, normally there should be 6 or less white blood cells in the spinal fluid. So if we see any more than that, we are concerned that we're dealing with some kind of inflammatory process. Now, to make things a little confusing, an acute intervertebral disc herniation can cause a little bit of inflammation in the spinal fluid too. So if there is just a small elevation of white cells, then we probably need to do some further tests to look and see if we're dealing with an intervertebral disc. If we are dealing with a meningitis, it is often sterile. Often it's mixed cells, and every once in a while we'll get lots of neutrophils in there, but that doesn't mean it's necessarily a bacterial infection. Bacterial infections are actually very rare in animals, and so are infections from other organisms like viruses or rickettsia, like Ehrlichia, Lyme's, or Borrelia, or toxoplasmosis or neosporosis, We very rarely see those, especially here in Florida. And so what we generally see is a sterile, steroid-responsive meningitis. Now, we need to do a myelogram if we are thinking that we're dealing with an intervertebral disc extrusion, because that's the only way you can actually see the spinal cord. The routine radiographs just don't cut it when you want to visualize spinal cord compression, because you can't see the spinal cord. All you can see are the bones, the vertebrae. So we need to go ahead and do a myelogram where we inject the contrast media in the spinal fluid that bathes the spinal cord and outline the disc compression. We can also see if there's a nerve root or spinal cord tumor in there that's either compressing the spinal cord or expanding the spinal cord, and we can tell if that's going on. So this myelogram is a very important diagnostic test to do for intervertebral disc extrusion or a tumor of the spinal cord nerve root. If we're dealing with a fracture, the treatment is going to be absolute rest and pain medication. Pain medication, pain medication, pain medication. That's a whole separate lecture in itself. But that's absolutely essential. And if the vertebrae are unstable or they have neurologic signs develop, then we need to, or the pain doesn't resolve, then they're going to probably need some type of surgery. So referring them to a facility that can handle that is going to be the next best thing to do. Now, if we're dealing with intervertebral disc disease, the treatment is, if they just have pain and no neurologic deficit, then the treatment is rest. Rest, rest, rest. No activity at all for 4 weeks. Now that is so hard for people to do, believe me, because after the dog gets to feeling better after a few days, they think their problems are over. They let the dog run around the house. He jumps up on the couch, jumps off the couch, and herniates that disc, especially if we give him prednisone or anything that hops him up and makes him really feel good. He's going to herniate that disc. It's going to go splat into the spinal cord and cause paraplegia or quadriplegia that now is much more difficult to deal with. So you just really have to impress on the clients that this rest is absolutely essential. Now, we can give them a little oral diazepam every 8 hours, and not more than 10 milligrams, but 0.5 milligrams per kilogram every 8 hours, and a little bit of prednisone, about 0.25 milligrams per kilogram every 12 hours or once a day, what it takes. But the main thing is, if you're going to give them the prednisone, you need to have them in a dog crate or in your hospital in a cage, because this rest is absolutely essential. So it just takes educating the client that this is the most important part of the treatment. The discospondylitis treatment is antibiotics for 4 to 6 weeks. It's really important, again, that you give these antibiotics for this prolonged period of time, because after a week or two, they might be feeling a lot better. And enrofloxacin or Keflex and trimethoprim sulfa, these antibiotics can be kind of expensive. And the people can say, well, he's not showing signs anymore, he's doing a lot better, I'm just not going to go refill this prescription. You need to impress on them that they need to give all the medication. I give them all, the whole shebang at the first time, because otherwise they might have to be tempted not to go back and get any refills. So they need to be on for 4 to 6 weeks in order to really kick this infection. Otherwise, they do better for a period of time, and then it comes right back on them. And the second time it comes back, the infection might be resistant to the antibiotics that we've chosen, and so be really difficult to treat at that point in time. If left untreated, it can go on to cause paralysis, and so we want to get on top of it early before it gets to that stage. It is often excruciatingly painful. So usually we can control the pain with Rimadyl or etegesic or something that is going to really help with bone pain, because it is a bone pain thing. Sometimes we have to go to heavier drugs like putting on a sentinel patch. It doesn't last very long in dogs. It takes about 24 hours to take an effect. But within the first few days, they're going to need something until the antibiotics start suppressing the infection. Meningitis. If there's an organism, then they have to be on the appropriate antibiotic or antifungal drug, but quite honestly, the prognosis is not very good. If they just have pain, it's probably better, but if they have pain and any kind of paralysis or anything, or weakness in the leg, paresis, then they may not do as well on treatment and may not be able to recover. But the good news is most of the meningitis that we deal with is this sterile type of meningitis, and if you give them prednisone, like 1 milligram per kilogram every 12 hours, or even a little bit higher if you need to, but usually that'll do it, they'll really improve, and you'll see that improvement within about 72 hours, and long-term the prognosis is good. Now, you never know exactly how long they got to stay on the prednisone, because you can tell, you can start tapering the dose, and if they start getting painful again, then you need to go back up on the dose for a few days and then try that for another week or two. And then if they start becoming painful again as you taper, you have to go back on. So you have to play, but usually it takes about 2 to 3 months and they can come off the medication totally. Okay, neoplasia treatment. Bone tumors usually have a very poor prognosis. But there are new treatments that are coming out all the time, and referral to a specialist is highly recommended because the oncologists that are around in veterinary medicine are really up on all the new treatments that are going on for bone tumors, and so there are things that can be tried. Nerve root and meningeal tumors, the prognosis might be good if they have surgery and you can get all the tumor out, but if they can't have surgery for some reason, or if you can't get it all, then the prognosis becomes worse. Lots of times we will do surgery and radiation in combination, and then the long-term prognosis a little bit better. But neoplastic cases are still a real challenge if it affects vertebrae or the spinal cord. But the time to diagnose it is at the pain stage before they have much in the way of neurologic deficit. Then the chances of help them are definitely better. Okay, so let's go on to the next problem, which is acute quadriparesis. Now, acute means that the signs have come on in 24 to 72 hours. And that quadriparesis, of course, is weakness in all 4 limbs. So this is oftentimes an emergency situation when there's acute quadriparesis or acute quadriplegia. And the lesion, where it's going to be located, are one of 2 places. It's either going to be something that's in the neck, in the cervical region, between C1 to T2, or it's going to be something that's affecting all of the peripheral nerves and muscles. These are your 2 choices of where your lesion's going to be. And they're very different disease processes, so it's important to differentiate these. Acute paraplegia is also an emergency situation, because that means paralysis of the hind limbs has occurred over a 24 to 72-hour period. If the spinal reflexes in the legs are present, the lesion is at T3 to L3. This is a very important point. So paralysis of the hind limbs with spinal reflexes intact, the lesion is T3, L3. This is the head is normal, the front legs are normal, it's just the hind legs that are affected. If there are no reflexes in the hind legs, but the head is normal, the front legs are normal, and the dog is paralyzed in the pelvic limbs, the hind limbs, and the spinal reflexes are depressed or absent, and that's like the toe pinch and the patellar reflex and all that. The lesion is down low, L4 to S2, because remember, if the spinal reflex is absent, then the lesion is at the level of wherever that spinal reflex goes through the spinal cord. It's either in the spinal cord at that level or the nerves carrying the information to the spinal cord at that level. So for the patellar reflex, it's L4-5. For the sciatic or flexor reflex, it's L6 to S2. And for the anal reflex, it's S1, 2, 3. So that's a very important point to know. If they have paraplegia and no deep pain, that's a very serious sign. Now, it's not hopeless, but it's a very serious sign. But it needs to be evaluated closely because they might still have the withdrawal reflex. All the time I get veterinarians that say, oh yeah, he's got deep pain. He pinches the toe and he pulls the leg away. That does not mean he is consciously perceiving the pain. That only tells me that the spinal reflex is intact. So if it's the withdrawal reflex of the hind limb, that means that L6 to S2 is intact. But it doesn't mean that the spinal cord is intact higher than that. So differentiating between the reflex and deep pain is important. If you have deep pain present, when you pinch the toe, whether he pulls it away or not, the animal should cry or turn and look at you or make some type of behavioral response that he feels it. And that's what's really important, is to monitor deep pain. There are several things that can cause acute quadriparesis and paraplegia, and these are the typical ones. Of course, spinal cord trauma, again, it's always in there in any kind of spinal cord condition. An intervertebral disc extrusion that has just exploded out of the space into the spinal cord. Might be painful initially, or it can be beyond pain. A fibrocartilaginous embolism. Now, this is the most common stroke-like condition that we get in small animals. This is where some kind of emboli, and usually they're cartilaginous, so we think they come from degenerating discs, are found in blood vessels that go to the spinal cord, and it is actually an infarction of the spinal cord. The blood supply gets cut off, and they go paralyzed. Now, the good news is most of them get better, but they look pretty bad initially, so you might have a tendency to erroneously give them a poor prognosis, so don't do that. So hemorrhage can also cause acute paralysis of the hind limbs or all four limbs also. So these are the four things that usually you're going to be thinking of. Excuse me. When they have acute paraplegia, it's really important that they be given this drug, methylprednisolone sodium succinate, 30 milligrams per kilogram. Because if they've had a spinal cord injury of any kind, and in the fibrocartilaginous infarctions or the disc problems, there are all these secondary changes that can go on in the spinal cord that the methylprednisolone sodium succinate will protect them from. It's a very powerful antioxidant drug. So the bottom line, if you have an animal that comes in with acute paraplegia, and if people want to do every single thing possible, you give them 30 milligrams per kilogram of methylprednisolone sodium succinate. Salumedrol is one trade name for it. You give them some kind of GI protectant like cimetidine or peptid-AC, famotidine, and then you refer them to an emergency center that can do surgical decompression, because there's plenty of experimental data out there to show that in this combination of giving them the salumedrol immediately and then getting them in for decompressive surgery immediately gives the spinal cord the best chance of recovery. This deal about waiting 3 days and see if they get better and then refer them for surgery just doesn't cut it. you're really doing the client and the animal a disservice, because after 72 hours, the odds go down. Even after 24 hours, the odds go down. So the sooner that you can give them this medication and refer them, of course, they got to be stable in order to travel, but as soon as you can do that, the better for the patient. And that's what we're here for, is to do the very best we can by these patients. So that's one of my soapboxes. So, of course, the radiographs of the neck and back can show fractures. They can show calcified disc material. They may be normal in cases of fibrocartilaginous embolism or hemorrhage because there's nothing to see. Every once in a while, they're normal in intervertebral disc disease as well. So we usually have to do a CSF analysis and a myelogram. The specialist that you're going to send them to will probably be doing this. And so you need to know what's going to be done because you explain it to the client. And so the spinal fluid usually has increased protein in it with one of these traumatic injuries to the spinal cord or infarcts. The myelogram can show spinal cord compression or swelling secondary to the disc problem. And the spinal cord may be completely normal. The myelogram could be completely normal if they've had an embolism or a hemorrhage. It also can be swollen, but lots of times it's normal. So without this myelogram, you really don't know what you're dealing with. The treatments are, certainly if there's a fracture or an intervertebral disc extrusion, we want to do this decompressive surgery as soon as possible, fix the fracture, and then they'll probably be continued on some steroids and some GI protectants, because if we don't give them some GI protectants along with those steroids, then they're going to get ulcers, and they could even perforate an ulcer, and that can cause complications that can lead to death. Now, the other thing that really bugs me is when people combine prednisone and one of the non-steroidal anti-inflammatory drugs like Etagesic or Rimadyl, or they give them aspirin. You never want to give a dog with a disc problem aspirin because they might have to go to surgery. And if they go to surgery, then they're going to bleed. And the combination of the steroids, any kind of prednisone or dexamethasone, and the Rimadyl or the non-steroidals is just causing, you're just looking for an ulcer to happen. So it really is a bad, bad combination, and we highly recommend against it. Thanks. Paraplegia and no deep pain after 1 month. If they still have no deep pain and they still have paraplegia after 1 month, they probably are not going to recover. But many of these animals do great if they're in a cart, and people can keep them that way, and they come along, they do fine. They don't go through all the psychological trauma that human beings that are in wheelchairs go through. And most of them are just fine, and they can be in their little cart for going for walks, and the rest of the time they just kind of drag themselves around and can lead pretty darn normal lives. I have many, many patients that way. For fibrocartilaginous infarct, we usually will give them the bolus of Solumedrol and then put them on a little prednisolone, again along with some GI drug like Pepsid AC, which is the famotidine, or cimetidine. And then it's just going to be nursing care, make sure they can urinate okay, and massaging the legs so that the muscles will stay good and the tendons will stay supple. And the prognosis is really good. In time, most all of them recover. It may take a month to 6 weeks, but they really show improvement over that period of time. And as all the dogs do with intervertebral disc disease and everything, it may be months. However, they come back and they really do great, and they continue to improve really for like 9 to 12 months after the spinal cord injury. So they need time. Our last problem that we're going to review is head tilt, nystagmus, and disequilibrium. And this, of course, is dysfunction of the vestibular system. Disequilibrium meaning a balance problem. I know you've all seen, those of you in small animal practice have seen cats and dogs that have come in with their head cocked to one side, the head tilt, and circling and falling and rolling to one side, and the eyes jerking with a nystagmus. The choices of where your lesions are in vestibular disease with these signs is either something out in the peripheral vestibular nerve, which is in the inner ear and cranial nerve 8, that's one choice, or something that's in the central nervous system in the brain stem or cerebellum. And they're very different diseases, and so that occur at these sites, and obviously the prognosis is better if you have something in the periphery rather than something central, so that's where we kind of like to put it, is in the periphery if at all possible. With cranial nerve 8, there is a head tilt, and if there is a nystagmus, there might not be a nystagmus. Sometimes there's just a head tilt. But in the really acute cases, there may be a head tilt, there may be nystagmus, there may be circling and rolling. But the key is, once that kind of calms down, there's no other signs. They're not paralyzed on one side of the body, or they're not hypermetric like they are with cerebellar disease. So you just have the vestibular signs alone, and that's it. If they have something in the brain stem, they're going to have all of these same signs as in the periphery, the head tilt, the nystagmus, all that, but they're going to be weak on one or both sides, and they're going to lose their conscious proprioception. Remember, conscious proprioception is tested by standing them knuckled on a limb and seeing if they'll just stand there. If they'll just stand there and you're supporting them, if they just stand there on the limb knuckled over, then there's something going on. And if they have vestibular signs in that, then the chances are it's in the brain stem. In central cerebellar disease, you'll have exactly the same signs as in the periphery, except for now you'll have hypermetria. Remember, hypermetria is like where they walk and pick up their feet too high, and you'll also have head tremors, intention tremors of the head, but you don't have any weakness. That's how you differentiate it from brain stem. But the same kind of diseases that get in the brain stem also get in the cerebellum. So these are the things that can cause peripheral vestibular disease. And things like a head trauma. If they get something that has caused a fracture in the osseous bulli of the ears. If they have an inner ear infection. Hypothyroidism can cause acute vestibular signs, so you should check the thyroid on all dogs that have this type of problem. And then we have an idiopathic vestibular syndrome in cats and dogs, and we can't find any cause of it, and they get better all by themselves. The same problem occurs in people. It's called Meniere's disease in people, but in animals we just call it idiopathic vestibular syndrome. It occurs very commonly in cats. However, we want to make sure that we rule out an inner ear infection in any animal that's come in with acute vestibular signs. The other point is idiopathic vestibular syndrome is common in very old dogs. And when it occurs in old dogs, then the tendency, they look so terrible. They're rolling all over the place, and their eyes are jerky, and they're all disoriented and disequilibrium, balance problems. The tendency is to say, oh, they're old, and, you know, we must have something really bad. They must have a stroke. They're not going to make it. And they get, unfortunately, they get euthanized. And all of these animals will get better, you know, so it's part of the art of practice is learning how not to get too carried away. Anything that comes on acute that's neurologic has a very good chance of getting better. And so just a little tincture time and serial neurologic evaluations can help a lot, especially in old dogs. Some of these dogs are like 16 and 17 years old when they get it. And they can completely recover or just have a residual head tilt, so it's important to know. So a differential diagnosis for central vestibular disease are certainly if they have a head injury, that can cause problems. If they have meningoencephalitis or some kind of infection in the brain. If they have some type of cerebral vascular disease like a stroke, and yes, we do see it periodically in dogs, but not very commonly, not like in human beings. And every once in a while, neoplasia will cause acute vestibular signs, but most of the time, that produces kind of chronic progressive vestibular signs. In peripheral disease, the treatments are, if it's a trauma or the idiopathic vestibular syndrome, they just get better without treatment, just in time. Now, during the acute phase, you might want to give them some meclizine hydrochloride, the Antivert. You'll have to look up the dose, but it's on all the formularies. You can give them that for a couple of days just to kind of settle them out. That's for motion sickness, because that's what it feels like. If they have hypothyroidism, you can treat that. But the bottom line is, most of the time, if they have peripheral vestibular disease, the prognosis is good, and the dog's going to get back to its normal routine, like bringing slippers to the client, and do pretty well. The only thing you have to be careful, especially in Florida, is if the dogs get into a situation where they fall into the swimming pool, they may look like they've totally recovered from their vestibular disease, and then they fall into the swimming pool, and the change in gravity decompensates them, and they start rolling around, and they can actually drown. So it's a warning that you need to tell clients that they have to be careful of. Okay? The treatment for peripheral things continued as inner ear infection. They need to be on antibiotics. Of course, we're going to examine the ear. If it's an external ear infection too, we can culture it. They need to be treated for 4 to 6 weeks with whatever antibiotics the culture and sensitivity say, or if you don't have culture and sensitivity available, then enrofloxacin. It's really important that you treat them early and for the entire duration. It's, again, like I said about discospondilitis, the people might think their problems are over, but they're not. And so if they're treated early and long enough, the prognosis is very good for recovery. If they quit treatment after a couple of weeks, then it'll return, and the infection will be very difficult to deal with at that time. The treatment for central vestibular disease, if it's a meningoencephalitis, and if it's again one of these steroid responsive meningoencephalitises, then they respond very well to prednisone. Now, we are able to actually measure serum titers for various organisms, like distemper and toxoplasma and neospora and aspergillus and cryptococcus and Ehrlichia, Lyme's, and Rocky Mountain spotted fever. Those are the main ones that we will evaluate if we have a meningoencephalitis. If all of those are normal, then we treat them with prednisone because we're probably dealing with some kind of steroid responsive. The prognosis certainly is going to vary with whatever the cause is, but for the steroid responsive meningoencephalitis, they end up doing very well and can completely recover. If they have a meningioma, a type of tumor that arises from the coverings of the brain in the cerebellum, that can oftentimes be removed, and their signs, and usually has to be radiated, and then their signs completely recover. The other tumors that might actually be right in the cerebellum that are primary tumors or metastatic tumors have a very grave prognosis, and if they are actually right in the brainstem, they can have a grave prognosis also. The brainstem is a hard area to get to surgically, so most of these have to be treated with some type of surgery. We are doing some experimental radioablative surgery that might be helpful down the line to patients that have brainstem tumors. So we're getting to find out what's going on. So the treatment of head trauma and cerebrovascular disease, most of them recover over time with just supportive care, time. And we're talking months. And again, most animals that have had any kind of injury, they're not completely as good as they're going to get for almost a year. So we've got nothing but time on our side. The main thing is patience. And so that kind of wraps it up. I'll be more than happy to answer any questions in the question and answer period. If you want to review, the best neurology textbook right now is Veterinary Neurology by Oliver and Lorenz. and Carnegie, I think, is on this latest issue. And it's large animal and small animal neurology. That's something you can study right away. In the summer, we have a book coming out. I'm one of the authors on neurology for the general practitioner, small animal neurology for the general practitioner by Teton New Media. And it's a very practical, problem-oriented approach, much like my lecture was. And so hopefully you'll find it useful as a reference text later, if it won't help you study for this exam. But I wish you the very best of luck on your exam, and I will see you all in the question and answer period. Have a great day. Bye-bye.